Thank you for coming. And again, I know I'm competing against the parks on Halloween, so I appreciate this very much. I'm Katherine Nickels. I'm one of the pediatric epilepsy doctors at Mayo Clinic in Rochester, Minnesota, where I'm an associate professor of neurology and also the medical director of the EEG lab. And today I'm going to talk to you about why we do genetic testing in epilepsy and what all of it means. All right, so only disclosure, yes, I have lots of pictures in there. They're all of my own children at various ages of life. Because if there's one thing that I have learned over the many years of doing presentations is that if you're looking for pictures of children, those of your own children are not copyrighted. So they're just in there for fun, used with they're all adults, used with their permission mostly. They know that I do it, even if they don't necessarily look at every single talk. They usually just ask me what disease I've assigned to them for today. So what we're going to talk about is what is genetic testing, why we do it, who should undergo genetic testing, because not necessarily everybody needs to, and we'll go through some examples of how doing the genetic testing made a difference for what we did. So starting off, what does genetic testing mean? When patients come to me and say, oh, well, we've had genetic testing, that most importantly doesn't necessarily mean that you've had most up-to-date genetic testing. Negative genetic testing doesn't necessarily mean a genetic disorder. So again, what are we talking about with genetic testing? We're looking for changes sometimes down to the very tiny single nucleotide variant. So just a single little base change can make a huge difference. We might be looking for a copy number variation, so duplications, deletions, triplications, and then we compare it to references, and we know that some changes are really common in the general population, whereas some are really uncommon and closely linked to disease. So just because you have a genetic change does not necessarily mean that that genetic change is causing your disease. And again, we classify it by how much they are known to cause disease, which means sometimes you might see pathogenic, meaning yes, this is definitely linked to a known syndrome, or we might see variant of unknown significance, which really means, yeah, we just don't know. So when we're doing genetic testing, we might do it as single gene sequencing. This is what was done all the time back when I first started practicing medicine. You know, we would see patients based on their history, their exam, etc. We would try to hypothesize what their syndrome was, what the known genetic changes were with that, and we would specifically test for that change. We still do that for some diseases because some diseases are so closely associated with just one change. So we might still do that. And then other times, we might do bigger, we might look at karyotype, so that's looking at the overall shape, numbers, look of the chromosomes. So for example, if we thought that someone had trisomy 21 or Down syndrome, we could do this through karyotype testing. So it's going to pick up bigger changes. Or we might do a little bit finer detailed testing with a chromosomal microarray. That, again, is not epilepsy specific at all. It's looking at the most common gene changes seen with a variety of disorders. So especially if a child or an adult might have epilepsy, might have developmental delay, then we might do, again, a little bit more broad spectrum. I think of this as an overall screening tool and might be done with that karyotype. So again, really good for screening. But then sometimes we get into more detail. This is now the next generation sequencing. So it's rapid sequencing of a lot of data, large DNA segments, and then they go through and they analyze it. So this requires extensive interpretation, again, a lot of data. It may be compared to parents' DNA because, again, everybody has gene changes, right? It's what makes identical twins, not 100% identical. Everybody has those changes. The question is, does this gene change cause whatever we're looking for? So, you know, if we see a variant of unknown significance, we see a gene change, we're not really sure, we're going to go back and test the parents. And if parents had the gene change but don't have any of the clinical symptoms, then they're probably not related. It was probably just a gene change inherited from parents and not associated with the syndrome. So we'll typically go to that if we can't find the answer through those screening with the karyotype and microarray. And then, if we can't find the answer through more specific panels, we might move on to whole exome sequencing or whole genome sequencing. So when we do these gene panels, that's when we're starting to take into account the clinical picture too. So for example, we'll do an epilepsy gene panel. One of the ones that we use most commonly tests for, I think it's 302 of the common gene changes associated with epilepsy. So it's not just looking for changes, it's looking for the changes that are consistent with the disease in question. And then we move on to whole exome and whole genome testing, which again is even broader. We're looking at even more information, and those are always done or preferentially done as a trio, comparing that person with the genetics of their parents, just because again there is so much information we need to go through a bit of a filter. And these can take a little longer to get back. The whole exome, whole genome testing, sometimes there's a little battle to get insurance coverage for it, and you know, can take weeks to months to get back. So why don't we just test everybody? You know, what are the downfalls to genetic testing? So the first thing is genetic testing is not perfect, right? A normal genetic test does not mean no genetic cause. What it means is no genetic cause identified, but we're always practicing within our current understanding. And I gotta tell you, the science of genetic testing has just exploded over the last 20 years. You know, I still remember back when the first epilepsy panel was available. This was, I'm trying to think, maybe 15 years ago. And that's it. And remember I told you our current epilepsy panel is about 300 genes. Back then it was a really big deal that we could get this early onset epilepsy panel. Again, 15 years ago. Guess how many genes were on that panel? Shout out a number. 4. This was a big deal. Yes. Yeah, so if that gives you any idea of how much genetic testing has just really exploded over the last couple of decades. So just because we haven't found it now doesn't mean we won't find it in the future. It just means we haven't found it now. I have I have families, I have identical twins who have epilepsy. Clearly it's genetic, right? You know, you have identical twins who have the same syndrome. Clearly it's negative genetic testing. So just because your genetic testing is normal does not mean it's a genetic disease. The other thing too, just because genetic testing is positive, just because a disease is genetically based, does not mean it's inherited. So that's the other thing that families will say, well, you know, it can't be genetic because there's no family history of epilepsy. But the reality is the patients who are most likely to have a genetic change causing their epilepsy, it's a new genetic change to them. So just because it is genetic does not necessarily mean it's inherited. Or sometimes, this is very rare, it can be inherited. It's a spontaneous change in either of the parents, but it's, they call it germline mutation, so the genetic change is actually at the egg or the sperm level. So if you do genetic testing on the parents, it's going to be negative, right? Because we don't typically test sperm and eggs, we just test blood. So what that means is if you have a known genetic cause, test the parents, they don't have a genetic cause, it doesn't guarantee that other kids might not have the same genetic change. So, you know, genetic testing can wind up being pretty complicated. Or sometimes you have something called mosaicism, which means some of the cells have the gene change and others don't. So whether you pick it up just means you have magically gotten the right cells. And finally, when we're doing genetic testing, there is always the possibility that you could find other diseases outside of epilepsy. So when doing genetic testing, it's always recommended that you work with a genetics counselor who can help us navigate all of those results. So why are we going to do it? Why do genetic testing to begin with? For a variety of reasons. And some of the argument is, well, why bother doing genetic testing? It doesn't really change what you do, right? You can't change genetics. But I would argue that is not at all true. For one thing, let's face it, finding an answer is really good. It provides some closure. It gives you a diagnosis. It gives you a group of people, a family support group, other people who have the same genetic change. It just, there is a lot to be said for that peace of mind that gives you closure. Also, the question always comes up, well, what are the, should siblings be tested, or cousins? What's the possibility of other family members having the same thing? You can't do testing if you can't identify it in the first place. So if we can find that genetic change, then we go back and test the parents. If the parents don't have the genetic change, then the likelihood is that no other family members will be affected, so we can stop there. As we have gotten better with genetic testing, we have also gotten better with treating based on genetics. So this is where I would argue knowing the genetic change actually does make a difference. We are now on the frontier of being able to do treatments at the genetic level. Now, these are not FDA approved yet, but they are currently in trials. So that's issue number one. We can actually help at the genetic level. Issue number two is if we understand what the genetic change is and where that genetic change fits in that seizure pathway, it helps guide the medications we use. And that we're doing right now. Now we even have medications that are specifically FDA approved for syndromes due to known genetic changes. And then finally, it helps us determine outcomes too. I'm in the pediatric world, so one of the most important questions is, okay, pull out your crystal ball. What is the future going to hold? Now, I don't have a crystal ball, even at Disneyland on Halloween, but the closest I have is knowing the cause, knowing the syndrome classification. So if we can identify that genetic change, it makes a big difference for guiding treatment, guiding expected outcomes, guiding what kind of monitoring is available. Let's face it, a lot of genetic changes don't just cause epilepsy, right? Epilepsy does not exist in a vacuum. There are many other organs that can be involved. It can affect learning, it can affect behavior, and so it helps guide the different monitoring that we need to do. So this is where I always like to throw in my little synapse or pharmacology detour. And yes, I do actually draw this out in the clinic while I'm talking about medications, because I think if you're going to prescribe a medication, it's important for families to understand where and how that medication works. The good news is, a simplified version, anti-seizure medications work at just a handful of places. They really do. So if we can understand that handful of places, it makes a big difference. So here's what we have. We have the synapse. This is what happens during normal synaptic transmission or action potentials. We get the calcium coming in, it's going to work, and then the calcium causes these little glutamate. Oh, you can't see my cursor, can you? Oh well. So, causes these little glutamate, there we go, vesicles to bind. They move across the synapse. They join up with AMPA and NMDA, and then we get sodium coming in, and we get our action potential. And then we have to shut our action potential off by potassium going out. We maintain it with chloride. Most of our medications are going to work there. So if we can understand where that genetic change is, and if it's a loss of function or gain of function, it is significantly going to affect the medications we use. Best example is Dravet syndrome. So the vast majority of Dravet syndrome is due to a change in SCN1A, which is a sodium channel mutation. It is a loss of function mutation. So the last thing we want to do for a Dravet patient is put them on a medication that works at the sodium channel and blocks the sodium channel. Does that make sense? So, knowing that genetic change, knowing where it is, really makes a huge difference for the medications that might be better, but also for avoiding the medications that could make things worse. Okay, so back to genetics. And yes, I do actually draw that synapse out because, again, it's important to know where medications are working on that path. If you're on more than one medication, we want to make sure that we're not doubling up and using multiple medications that are just hitting the same site. So you want to know where each of your medications work in that pathway. All right, back to genetics. So who are we going to test? Genetic testing, again, is a big deal. Sometimes you identify things you didn't want to know about. It is costly, it takes a long time to do, so this isn't something that we're just going to randomly do for everybody. We're going to focus on those that have a higher likelihood of having a genetic cause for their epilepsy, which means family members with related syndromes. What do I mean by a related syndrome? So, say I'm seeing a child who has epilepsy, second cousin also has epilepsy, second cousin has epilepsy due to a known traumatic brain injury. The two are probably not related. So talking about other family members that are similarly affected. And again, genetic testing does not mean inherited. So even if there is no family history of epilepsy at all, we're going to be testing those with drug-resistant epilepsy of unknown cause. So, no history to explain it, no MRI imaging to explain it, especially if it's early onset. The little kids, the very early onset, are much more likely to have a genetic cause for their epilepsy. Sometimes neuroimaging, so brain MRI, can give us the answer, but there are certain structural brain changes that are known to be associated with genetic causes. So the structural change is causing the seizures, the genetic change is causing that structural change. So based on what we see on the MRI, that might help us guide whether or not to do genetic testing. If there are other features that suggest, we're dealing with something beyond just seizures, beyond brain involvement, then we'll do testing. And definitely if there's a progressive course. So not just epilepsy, but we're seeing other decline, we'll do our genetic testing then. So we'll move on to some case examples of how understanding the genetics makes a difference for what we do. And I have them grouped by age, so we'll start with the tinies. Sorry, this turned out a little bit blurry. So we have our two tiny tots. They both come in, they're both very, very young. Parents bring them in because of a question of seizures. No perinatal complications, so the pregnancy was fine, the labor, the delivery, they went home with parents right away, no concerns at all there. No family history of seizures, developmental delay, epilepsy, nothing at all in their family history. They're otherwise healthy, as much as you can say in a baby that's, this big. They're doing their baby things, which means that they are feeding and they're waking up and they're sleeping, and that's about all babies do, right? So what's the difference between our two tiny tots? So this one is only 4 weeks old, and she's coming in with spells where she keeps crunching down like this. At first they thought maybe she was colicky. I mean, she is a month old. I don't know if you guys have kids, but that's, they're good at doing that at that age. It seemed to occur more with feeding. They tried to change her formula. They put her on a soy-based. Didn't seem to make any difference. And in fact, she was actually getting fussier, and she was doing these more, and she did them more so when she was first waking up. So eventually they weren't even associated with feeding. We did an EEG on her, which is what we do, right? So we brought her in to the EEG lab, and I know you guys are not EEGers, but this is what an EEG looks like when we do that. So we have lots of our different brain waves, and you will notice this child has flat brain waves. So I can tell you, a 4-week-old does not typically have flat brain waves. They have brain waves going on. They don't look like adult brain waves by any means, but they have brain waves. And she was wide awake, and her EEG spent a lot of time being flat. And then we recorded right here, you can see spikes coming up. We recorded a focal seizure, and then we recorded the event of concern. And we see a big spike and then flat. And that is consistent with an infantile spasm. And that's really young to have infantile spasms. Most of the time they're more like 6 months. So now we have a tiny 4-week-old who has multiple seizure types, is very, very fussy. We can't really comment on development because she's 4 weeks old. Our second baby is 2 months old, which means we can comment a little on development. You know, a 2-month-old should look around. They should smile. Again, that's about it. This little 2-month-old also has multiple different seizure types. And in fact, her seizures, you know, she will start doing one thing. During that seizure, she will shift to another and then shift to another. Again, we hooked her up to EEG, and EEG showed exactly that. It would start in one place and then go to another and then go to another and to another, almost like waves. And within days, she stopped smiling, she stopped looking around. So both of these are a pretty concerning picture. And honestly, when tiny babies show up with epilepsy, that's a concerning picture. So that's where we're going to do genetic testing pretty rapidly. Yes, we do neuroimaging on all of them too. And so we're suspecting early onset epilepsy syndromes, and we're going to come again right away, and we're going to do pretty expansive genetic testing. Now at Mayo Clinic, we are very fortunate that we actually can get rapid whole genome testing done on these tiny babies and get answers back within days. And important because, again, you can imagine early onset epilepsy is going to significantly affect outcome, and sometimes understanding the genetic change makes a difference for treatment, which is now going to make a difference for outcome. And so our first little baby has what used to be known as Ohtahara syndrome. Now it's early infantile developmental and epileptic encephalopathy, or ID. And 20% of these are due to a potassium channel. So if we go back to our little change, yes, there are medications that work on the potassium channel. We also know medications that work on the sodium channel can be effective for this seizure type. And this is an epilepsy syndrome that's known to be very, very difficult to treat. So the best thing that we can do is recognize those preferred medications and get started on it right away. The second one has something called epilepsy of infancy with migrating focal seizures. And again, often due to potassium or sodium channel changes. And unlike our Dravet syndrome, where we don't want to use our sodium blockers, we want to use our sodium channel blockers on these and try to get control. So we would have no way to know preferred medications if we didn't come in and do that genetic testing earlier. And again, half of them are due to a known potassium channel change. So take-home points from our tiny tots. Who are we going to test? Those with very early onset epilepsy. Why? Because it helps guide our medications. So then we move on to our thought-provoking threesome. So now we have infants. All of them are 6 months old. All of them have no prior medical history, normal growth and development. All present to their pediatrician and then referred to neurology with a question of new onset seizures. So what makes these little babes different? So our first baby, she has a 1-week history of recurrent spells, mostly when she wakes up. She again is flexing at the waist repeatedly, and then she cries. She stops sitting and rolling over. She's very, very fussy. So she's sounding a lot like our first little tiny baby. And parents said, as far as past history, all we know is before she was born, when they did the ultrasound, they said that she had something on her heart. They did an ultrasound right when she was born. They did that echocardiogram and it was gone, and they said that she was healthy and she was fine. So that's the first baby. Our second baby came to the emergency department after having a convulsive left-sided seizure that went on for 30 minutes. He did have a fever at the time. And actually 2 months ago, he did the same thing, but it was over on the right. And there is a family history of febrile seizures, not epilepsy, but febrile seizures for him. And then our third baby was kind of like our second one. Came to the emergency department, had a fever, did the same thing 2 months ago. The difference for her is instead of having a single prolonged seizure, she's having clusters of seizures. That's just, this current cluster has been going on for 30 minutes over and over again. Her parents are healthy, but when they went back, her father's mother, so paternal grandmother, actually has epilepsy that she never outgrew, and she has a learning disability. So we're going to go back and we're going to think about these babies. So the first baby, that heart thing that went away, is actually a huge clue, because when babies come in and we're questioning infantile spasms, biggest cause is tuberous sclerosis complex. And it has such a known genetic change, we're not going to mess with all of our panels. We're just going to go for the money, right? And we're going to do genetic testing. We're going to look at her MRI, and sure enough, we're going to see all these little spots here, there, there, that are consistent with tuberous sclerosis complex. That often is associated with some skin changes too, where we see little white spots. But you know, this is a little pale-skinned Minnesotan baby. She doesn't have any pigment on her skin yet to show any of those pale spots. We do try to look at them under what's called a Woods lamp, and it'll make them come out. Basically, it's kind of a black light, and it'll make them come out, but you know, we couldn't find one in the emergency department. But nonetheless, that heart thing, they do have a known heart thing called a cardiac rhabdomyoma that goes away on their own, known brain thing, and that's going to be important. So we're going to dive right in for a single gene testing. We're going to look for tuberous sclerosis complex, and sure enough, that's what she has. Why do we care? What's the difference? This baby is having infantile spasms, and if a baby is having infantile spasms, there's only 3 medications that are used to treat them. Regular seizure medicines work less than 10% of the time, and we know that the kids with tuberous sclerosis preferentially respond to vigabatrin, so that's what we're going to use. We also know as she gets older, there are medications that where tuberous sclerosis complex is one of the indications. One of the big ones is cannabidiol. You know, this is pharmaceutical grade brand name Epidiolex. Tuberous sclerosis is one of the indications for it. But let's say this is different. What if, you know, this is a healthy baby, but what if she presented she was not developmentally healthy? You know, we suspected she couldn't see because she didn't visually track. At 6 months, she wasn't holding her head up, she wasn't smiling. MRI didn't show those changes. Well, now we don't have that clear, just going to go for one genetic change. Now we're going to do more of a broad screen microarray karyotype, might do an epilepsy panel, whole exome sequencing, because now we're looking for other genetic causes, most commonly something called CDKL5, and there is a medication, ganaxolone, is specifically FDA approved for epilepsy due to CDKL5. So just those subtle differences will change the testing we do, which changes the treatment. Our second baby with our 30-minute prolonged seizure with fever, of course, has Dravet syndrome. This is what they do. Often they'll be one side, but they might switch from one to the other. And during that first year of life, they have seizures primarily with fever, and then after that, they develop multiple seizure types. And the vast majority of these are due to a genetic change in that sodium channel mutation. Again, this is loss of function, so we're going to avoid our sodium channel blockers because that can make things worse. So we're going to test usually with either with an epilepsy panel or epilepsy panel plus a microarray. I do have one kiddo with Dravet syndrome. The epilepsy panel didn't pick it up, and it's because the entire section associated with that gene change is deleted in them. So we had to do the microarray to pick it up. And again, for Dravet syndrome, we know that there are preferred medications. We know that there are medications we have to avoid. We also know that there's specific counseling that we need to do because children with Dravet syndrome are much higher risk for sudden unexpected death in epilepsy or SUDEP. And then our last baby, who is kind of like our Dravet kiddo, except instead of having a single prolonged seizure, this baby is having clusters. And this baby has a Dravet-like syndrome due to PCDH19 related epilepsy syndrome. why does it matter? Why wouldn't we just say, okay, this baby has Dravet syndrome too? Why don't, you know, prolonged febrile seizure? Well, except if you have epilepsy not because of a change in sodium channel, that opens up all those medications. So we've now broadened what we can use for her. And this is a fun thing, just mostly for residents. It's an X-linked gene change, and you have to have interaction between the healthy and unhealthy X chromosomes to have symptoms. So fathers are asymptomatic carriers, which almost never happens in medicine. So her grandma being affected was important. So take-home points for these little ones. The clinical history and presentation are very important. Gene testing should never be done in a vacuum. We're going to do it with all of our clinical information and with our neuroimaging. Sometimes single gene testing is enough. Sometimes we have to go all the way to panel or whole exome sequencing. And yes, it makes a big difference for how we treat. We move on to our toddling trio. So now we have, again, normal growth and development. They all had a convulsive seizure at age 18 months and then presented at age 2 years for seizure recurrence. So what makes these kiddos different? This babe had the seizure at 18 months. It was felt to be a febrile seizure. At 2 years, it was a generalized tonic-clonic seizure. But again, it was a single one. Went along just fine for another 6 months, but then developed myoclonic seizures. So that's when medication started. At age 3 years, was on multiple medications and ketogenic diet because medications weren't working. And during this time, between age 2 and 3, she had what's called a progressive course, right? She's started with one seizure type, another seizure type, seizures have increased in frequency, seizures are more severe, and she's losing developmental milestones. She starts falling down a lot, she stops talking, and now she requires glasses. So the first test we do anytime kids come into the epilepsy clinic is an EEG. And we typically do our little flashy lights. It's one of our favorite things to do with EEG. We're looking for a change. Most often if you get seizure-related changes on the EEG, it's when we do the flashy lights faster. But this babe is doing it at the slow flashing lights. And that is actually very important. And then our next one, when seizures came back at age 2, they were really just staring spells. They were worse in the morning, or if he skipped a snack, especially if he slept in and missed breakfast. And when we examined him, he looked like a very, very healthy little guy. Everything measured out okay, except his head circumference was 20th percentile, which, it's fine. Not, I'm probably a 20th percentile head. That's fine. Except I was lucky that time around that this child brought multiple family members. So I actually went around the room and measured everybody's head, and the family was all 80th percentile. So this is a relative microcephaly. This is not normal. And when I was watching him in a stroller, he just kind of sat there and wiggled the whole time. I said, well, this is not right. No family history of epilepsy. Mom gets really bad leg cramps. If she exercises, especially if she doesn't eat before exercising. And yes, these were absence seizures. And then our last one, when seizures came back, these were now focal seizures. She would look really fearful. She had left eye and head deviation. She would stop. She'd be unresponsive. She's tried 5 different anti-seizure medications, normal growth and development, but a little bit of concern recently with that growth and development. And her MRI is abnormal. She has a focal cortical dysplasia. Father has a history of focal epilepsy, normal MRI. Grandmother has a history of focal epilepsy, but they're all seizures involving different parts of the brain, and we don't know about grandma's MRI. So what are we going to suspect in these little toddlers? For the first one, that response at the slow flash frequency is very concerning for a particular disorder called late infantile neuronal steroid lipofuscinosis, NCL2. And there is treatment for this that slows down the process. It doesn't stop it. It doesn't reverse what has happened. So you have to pick up on it right away. to be able to treat. And so we're going to do more targeted testing for that one. And again, there's enzyme replacement therapy, but you have to treat it right away because it just slows down the decline, it doesn't stop it, and it doesn't reverse it. Our second one has adsons epilepsy that started prior to age 3. So this is concerning for a what's called a glucose transporter deficiency, which means you can't move the glucose from the blood to the spinal fluid. So these little brains are starving. And that's not good. That's why his little head was small. His brain is starving. Your brain can only run on 2 forms of fuel, either glucose or ketones. So if you can't move glucose to your brain, it means you have to treat with ketogenic diet. You have to provide them with an alternate source of fuel. So we're going to go in and test right away for the glucose transporter deficiency. And then our last one has what's called familial focal epilepsy with variable foci. Sometimes there can be MRI changes, sometimes there isn't. How does this one affect what we treat? Anytime we have focal epilepsy that's hard to treat, you know, she's tried 5 different medications, we always think about surgery. And your genetic change makes a difference for whether or not you're a surgical candidate. So if she has a genetic change in DEPDEC5, then she is likely to be a good surgical candidate. Whereas if she had a genetic change in, you know, again, one of our sodium channels, potassium channels, even with that MRI change, she's not a good surgical candidate. So knowing that genetic change makes a huge difference. So our take-home points from our toddling trio, confirming the diagnosis, again, makes a significant difference for treatment. Some underlying causes require more than just medications to treat. Sometimes we need keto diet, sometimes we need surgery. And then last but not least, we can't forget about the older kids. So we have our adolescents, bless them. So we've got a 13-year-old who comes in with her first time generalized tonic-clonic seizure. You know, she was staying up all night at a friend's house, New Year's Eve, watching movies, playing video games, has a convulsive seizure. Classic story. We go in and we ask her and say, by the way, any warning? Nope, nope, nope. Any concern about development? Nope, nope, nope. How about in the morning? Do you ever spill your juice? Oh yeah, all the time. Okay, so we know what we're dealing with. And yes, she's got a typical EEG consistent with generalized epilepsy. This sounds like juvenile myoclonic epilepsy. Okay, so, you know, start her on medication. Caution that, yeah, this is one that doesn't typically resolve spontaneously. 70% of the time responds well to medication. Half the time there's a family history, but we almost never find it. Again, this is another situation. I've got twins who have juvenile myoclonic epilepsy. We can't find the genetic change. This is, you know, felt to be pretty complex genetics. Lots of times there's a family history. So we're actually not going to do any genetic testing on her because this is juvenile myoclonic epilepsy. There isn't a big role. Until age 15. You know, she was on levetiracetam, Brendan Keppra, doing great, you know, maybe a little cranky, but that was attributed to her being a teenager. So fine. But then seizures came back. First convulsive seizures, and then those myoclonic seizures came back, and then the myoclonic seizures got worse. And they weren't just first thing in the morning when she was getting up. It was happening when she was writing, so she wasn't able to do her schoolwork. They actually had to assign someone to do her writing for her. And then over time, they started to show up when she was walking. So, you know, her walking became unsteady. She wound up in a wheelchair. She was still doing pretty well, but maybe there was some concern that her grades were starting to decline. And unfortunately, right at this time, her little sister had her first unprovoked convulsive seizure. So now what are we dealing with? This is not juvenile myoclonic epilepsy. This is, again, a progressive course. This is a progressive myoclonic epilepsy. What's the difference? Her myoclonic seizures are interfering and are actually worsened by whenever she's trying to move. This is called action myoclonus. And so the most common progressive myoclonus epilepsy at this age is type 1, also known as Umbrach-Lundberg disease. shows up between age 6 to 15, variable severity. Commonly there's a family history. Myoclonus is the first symptom, and then it's a progressive course. And so we do more targeted testing. This is an unstable gene expansion. And so we're able to make that diagnosis for both her and for her sister. So what testing? Again, this is very suggestive of that underlying syndrome. Keep in mind, if we had gone with just our panel, microarray, whole exome, whole genome sequencing, does not reliably pick up on expansions. So we needed to do targeted testing for that gene change. So who are we going to test in this situation? We're going to test those with progressive cognitive decline, those with action myoclonus. If myoclonus is affecting their ability to move around, they're becoming unsteady, that's cerebellar signs, changes, progressive changes, including those on EEG. And why? Because, again, identifying that specific cause makes a big difference for treatment and expected outcomes. So our take-home points for genetic testing. Genetic testing is not perfect. Overall, it helps identify the cause 10 to 50% of the time. Again, the littler kids were more likely to be able to pick up a genetic change. So we don't always find a cause. Overall in epilepsy, we're able to find a cause about half the time. And most people tell me that that's ridiculous and really not good enough. And I completely agree. We're working on it. But I also challenge you to compare it to other chronic diseases where we don't find the cause ever. So in the world of epilepsy, we're not doing too bad. Why do we do the testing? Because finding a cause, again, helps determine the likelihood of other affected family members, guides treatment, provides answers for long-term outcomes, and just overall provides answers for why. Why that person is affected. We're going to test those if there's a family history of similarly affected family members, drug-resistant epilepsy of unknown cause, early onset epilepsy of unknown cause, progressive course, normal or diffuse changes on imaging, or if there are other features that just suggest an underlying, a specific syndrome. Some clinical pictures warrant more focal testing, like glucose transporter deficiency, Dravet syndrome, tuberous sclerosis. Sometimes we need to move on to microarray and karyotype screening, and then moving on to more of an epilepsy panel or whole exome and whole genome testing. This is a little plug again. I don't work for them at all, but there is free genetic testing for children with epilepsy onset under age 8 through the Behind the Seizure program. And that's it. Any questions? And this is the only request that my children have, that I show an updated picture of them not having anything. Yes?
Can you tell me more about long read sequencing?
About what?
Long read sequencing?
No, I don't understand.
I've been told that it's sequencing further rather than chunks, but the whole chromosome multiplied. It comes after the whole genome sequencing?
No, my understanding goes, again, I'm not a geneticist, so I'm comfortable testing up to whole genome testing, but haven't gone beyond that, so sorry.
Okay, because we have a child through the Broad Road Institute, through the Rare Genomes Project.
Perfect.
And I was told that if your child, we have a child who came out with something with WES, then the WES showed nothing, so they're going to send them over to the long read automated sequencing.
Okay.
So basically, we're still trying to figure out what is going on with the variants that it does have.
Okay, good. Yeah, and that's exactly what you should do. So if you have variants, or if we don't find the answer, you don't stop there, right? And so it sounds like you're doing exactly what you should be doing. You're using, pushing to the extent of genetic testing that's available. And then most of the time what's recommended is, if you don't find the answer, come back in about 3 years, because technology will have changed again. The other nice thing is, once that genetic testing is done, and our understanding of specific changes increases, the more patients we test, sometimes genetic changes will be reclassified over time as pathogenic, and most labs hold on to to the genetic sample, and so they will go back and rescreen. So sometimes even without coming back, you'll suddenly be notified of, oh, this this variant of unknown significance has now been reclassified and we think is causing your child's symptoms. Any other questions?
Anything happening on the gene editing also, or anything that
Right now, the one that I'm most familiar with is, we're studying oligonucleotide changes in Dravet syndrome, and those are currently in trials. There's nothing that's FDA approved yet.
That's not actually gene editing.
Yeah. Thank you.
But it's sorry, I'm next, and one slide on that. But
yeah.
Ultimately, they like to be very cautious about the wording.
Yes. Yes, that is very true. Thank you. Any other questions? All right. Thank you very much.